Welcome back to Beyond the Dental Chair, where we explore ways to elevate your practice. I'm your host, Brittany Murphy, the myohygienist, and today we're going to dive into a critical topic: how to spot the most common airway issues during a routine dental cleaning. So I'm trying a little something different with this episode. As you see, I am sharing a PowerPoint presentation. Let me know if you find this helpful to have the information up on the screen. If you rather just listen to me, have a conversation, more like you're, sitting at my kitchen table. But I would love the feedback, whatever you feel would be most helpful or beneficial. Definitely just let me know. So it's really important that airway health is talked about in a dental setting. It is really the cornerstone of systemic wellness. And we know all about the oral systemic link, and airway health is at literally the center of that. And as dental professionals, we see our patients the most out of all healthcare providers. So we're at that forefront, we're on the front lines where we're able to identify these signs and symptoms that are linked to issues like obstructive sleep apnea or chronic breathing, which is going to impact sleep, the way our body really works. I mean, I have cardiovascular health written here, but really every organ system, our oral health, and really our overall health. So, signs that I want you to start watching for during a routine dental cleaning. This should not take a lot of extra time. If you think about it, we're already in that space for 45 minutes to an hour. So, who better than to assess? Okay. These are, again, more of the common signs that we may see. There are some other ones that we can go over in another episode, but I want to kind of give you a short list. So, enlarged tonsils or uvula, tongue posture and size, signs of mouth breathing, tooth wear, scalloped tongue, and nasal obstruction. When we're looking at tonsillar size, really what I suggest doing is if you look at that, the back of the throat, if you look at that oral pharyngeal space, the way that we grade tonsils are on a scale from grade 0 to grade 4. Now, 0 meaning that they were surgically removed. So if you're not seeing them, of course, you can ask the patient if they had them out. And usually they'll remember, but not always the case. And then I want you to look at that space and I want you to think how much space is being occupied by the tonsils. If it is less than 25%, we're looking at a grade 1. If it's somewhere between 25 to 50%, we're looking at a grade 2. If we're looking 50 to 75%, grade 3. And then those kissing tonsils are a grade 4. Now, the other thing that you can look at is that low hanging uvula. I mean, think about how these tissues are really going to obstruct the airway. And especially when you're laying in a supine position, when you're sleeping at night, think about what that low hanging uvula can really do, right? Think about what weakened oral pharyngeal muscles, what's going to happen when we're laid back. Okay, that tongue, if it's not suctioned where it should be, is going to fall and block the airway. And if these tissues are not as strong or not as toned as they should be, what's going to happen? I mean, those tissues, I hate to use the word saggy, but if those muscles are not tight, it's going to cause even more obstruction. So we really want to make sure that those oral pharyngeal muscles are working and functioning as they should. And then, tissues, again, like our tonsillar tissue, our adenoid tissue. Adenoid tissue, you can't see. You're not going to be able to see that clinically. It's going to be more on an x-ray. Or if you send the patient to an ENT where they would perform a scope, we'll be able to assess those adenoids. Please keep in mind, just because somebody has enlarged tonsils does not mean they have enlarged adenoids, and vice versa. If somebody has enlarged adenoids, it does not necessarily mean that they have enlarged tonsils. But enlarged tonsils are certainly going to serve as a barrier, as an obstruction for that airflow. So myofunctional therapy, establishing dominant nasal breathing patterns, reducing inflammation through diet and other means, getting to that source of that inflammation is really going to be key, and a myofunctional therapist will really be able to help with that. Tongue posture and size. So look at that tongue. Does it look too large? Is it resting against the teeth? Is it resting in the bottom of the mouth? We want that tongue resting all the way up in the roof of the mouth. The tip, the middle, and the back of the tongue should be lightly suctioned, okay? We don't want to have the tongue in the bottom of the mouth or the middle of the mouth. We don't want the tip of the tongue up, but the back of the tongue down. We want that nice palatal suction so that when we do go to sleep at night and we are laying in that supine position, that tongue isn't just going to fall into the airway and further obstruct the airway more. Okay. And that's basically, you can see in this photo, what's happening is that tongue is really blocking off that airway. A good indicator about tongue posture, look at those incisive papilla. They should be worn down if the tongue is resting in the roof of the mouth. If they're like, speed bumps up there, more often than that, that means that that tongue really has never been resting in the roof of the mouth. Signs of mouth breathing. So, of course, look for oral dryness, oral redness, gingivitis. These can indicate chronic mouth breathing, along with, dry, cracked lips. If a patient's in your dental chair and they're like constantly whipping out their chapstick and using it, that can be a good indicator. When we see this flaccid, rolled out lower lip, that's an indication of mouth breathing. I like this photo here. So this photo is credit to Dr. John Mew. And basically what this is showing, it's the same boy. And basically it's showing what mouth breathing can do to our facial development. So in this photo, I want to say it was like his 10th birthday or something. This little boy got a gerbil from his parents and he ended up being allergic to the gerbil. Well, what happens when we're allergic to something? We become very stuffy, very congested. He became a chronic mouth breather. That jaw was open, that tongue was down, and look at the way that he grew, right? He grew downward and backward. We do not see any nice forward growth of the maxilla or the mandible. We're seeing this recessed chin. You can see this rolled out lower lip, this elongated nose, even this little hook right here, this long, narrow face. Look at this nice facial shape he had as a younger boy. These eyes just look very tired. These are all signs and symptoms of mouth breathing. Tooth wear. So excessive wear or flattening of the teeth may signal bruxism due to airway obstruction during sleep. So I know as a hygienist, especially early on in my career, I learned that if we saw, tooth wear, that is a sign the patient is clenching or grinding. They must be stressed. We're going to, recommend a night guard for them to protect their teeth because we don't want them cracking their teeth. Well, this night guard is not going to get to the root cause of the problem. It's not going to actually stop the clenching and grinding. It might protect them from breaking teeth, but it's not getting to the root cause. And sometimes these night guards actually make airway worse. So I strongly urge you, if you have a patient that is clenching or grinding, please rule out airway, get a sleep study done, perform an airway screening, refer them if you have to, but we want to make sure that there isn't really an airway issue going on. Now, I want you to think about, I have this photo here. Think about what our oral appliances that we give patients who snore or have sleep apnea do, right? They protrude that lower jaw forward and it helps to open the airway. Well, what researchers are finding is that bruxism is actually linked to our body's own protective mechanism to keep our airway open. If we think about what those muscles are trying to do, or the muscles that are activated when we're bruxing, those are the same muscles that are also going to help lower the jaw. Protrude the lower jaw forward and open the jaw. So it's the same mechanics, right? Our body is just naturally trying to open that airway. And that's exactly what we give patients these appliances for. So I want you to start looking at that tooth wear differently. Same thing with abfractions everywhere. It's not, I know that I learned, they brush too hard. A lot of abfractions we're going to see from a bruxism habit. So again, getting to that root cause of why the patient is bruxing is really important. And I can send you guys the research on that where it talks about it being the body's protective mechanism to try to open the airway. A scalloped tongue. So a scalloped tongue is going to suggest that that tongue is pressing against the teeth because there is not room inside the mouth. So oftentimes patients will say, I feel like my tongue is too big for my mouth. And our patients, along with us as clinicians, need to kind of spin that around. Is it that your tongue is too big for your mouth, or is your mouth not big enough for your tongue? Okay. This is a great book that discusses just that. 6-Foot Tiger, 3-Foot Cage by Dr. Felix Liao. The 6-foot tiger being the tongue, trying to fit into a 3-foot cage, the palate, it's not going to work. Where's that tongue going to go? It's not going to be able to go anywhere. It's going to kind of just, again, obstruct that airway. Press against the teeth, whether it's laterally or forward, and that's where we're going to see more of these scalloped patterns. So again, referral to myofunctional therapy, referral to an airway dentist to see what we can do as far as palate size and shape and growth. Of course, depending the age of the patient, there's different treatments, different tools and providers' toolboxes as far as what they can offer to patients. But again, we want to note these things and we want to be able to link it back to something for our patients. And then, of course, have a provider to be able to refer these patients to. Um, and that is, again, a sign or symptom that I remember seeing as a clinical hygienist when I didn't know anything yet about airway or myofunctional therapy. And, I would note it, like I would, note the scalloping pattern, but I never really dug deeper and I never knew what the root cause was. So again, we want to always think beyond the dental chair. Nasal obstruction. So if you have patients that are reporting difficulty breathing through the nose or congestion being noted, maybe you're noticing that they're very clogged up, they're, breathing audibly, just ask, have that conversation. Do you notice that you have any issues breathing through your nose? Or, would you consider yourself a nasal breather or a mouth breather? Look at that mouth posture. Is the mouth slumped open? Do you hear those breaths? Is the breath, very shallow? Oftentimes mouth breathers are going to have shallow breathing coming more from their, upper chest. Something simple, very simple that you can begin recommending to your patients literally tomorrow. You can start integrating, into even your routine at home as a family is routine preventative nasal hygiene. Okay. This nasal spray right here, X-Clair nasal spray or Clair nasal spray, it's a saline nasal spray with xylitol in it, which is an antimicrobial. This is the nasal spray that I like to recommend. It can just be a regular saline spray, that's fine. But the difference, the impact that introducing and implementing a routine nasal hygiene regimen can do for your breathing, for your sleep, for your overall, health and well-being it's invaluable. And it's something so simple. And anybody can do this. I mean, you can even use X-Clair on infants. It's safe for infants. There's a different bottle for the kids one, but it's the same exact ingredients, just the bottle's different, the marketing's different. And of course, the price is a little bit different. This picture here just shows the difference between a nasal breather and a mouth breather and how that face is going to grow and develop. So again, when we have that tongue resting up in the roof of the mouth and we are able to breathe well through our nose, the pressures from the tongue are going to help that jaw grow laterally and forward, anteriorly, right? So we're going to have that nice U-shaped arch. We're going to have that nice wider face. When that tongue posture drops, it's almost like the tongue acts like a scaffold for the upper jaw. When that tongue posture drops and it doesn't have that anymore, now we have imbalances between those facial muscles. And that's where we're going to see the lips and the cheeks win because it doesn't have that counterbalancing force with the tongue. And we're going to see that narrowing. We're going to see the narrowing in the dental arches, malocclusion. If that lower jaw is open because we're breathing through our mouth, that recessed jaw we're going to see. And just like that little boy's photo from 10 years old and on after he got his gerbil, you can see how the facial structure changes. There's elongated face, elongated nose, crooked nose, tired eyes, like poor definition of cheekbones versus our nasal breather in the top photo. So I want you to start looking at these signs, documenting these signs, having informative, sparking conversations, informative conversations with your patients, gentle conversations. Don't overwhelm them. Maybe, you kind of can tell that they're a little taken back. Document it, note it, follow up in 6 months or 3-4 months, whatever their, recall is. If you're finding something, noteworthy, and you need to have, that team, that network of providers to be able to make referrals to, make sure that they are more airway focused. Go to dental events and study clubs in your area and really try to begin forming those teams. And we can talk about ways to form those teams on another episode as well. And I apologize if you hear my baby crying in the background. She's not happy that I'm in here recording this and not out there playing with her. So I apologize if you hear that. She is a little bit attached to me, which I'm not going to lie, I do kind of love, but it does make doing things like this a little bit more difficult. So anyways, I digress. So really what we're doing is we're starting to connect those dots for patients. Okay. These are things that they aren't really thinking about as they're sitting in your dental chair. But what we're trying to do is we're trying to get them to think beyond the dental chair. We want you to think beyond the dental chair and how we could even further impact our patients' lives by spotting these issues that are very simple and quick to assess for. So thank you for joining. Please reach out with any questions if you have any topic suggestions. And until then, keep thinking beyond the dental chair. Bye for now, everybody.